So this is a topic some of you have heard me talk about before. It's a really big topic. We can't do it near justice in a half hour, but we can make some, I think, interesting points. And I'm going to assume that you guys already know a lot about this, but please stop me if you need. This is one of those sort of cautionary tales, the use of TPA, I believe, not only in stroke, but also in coronary disease, another fascinating story that we're not going to get to now. But in any case, this chapter starts out with the recognizing that the American Heart Association and the American Stroke Association have recently put out calls to have acute stroke centers. And abstract number 1 is one of the things that they published in various places saying that we need to have acute stroke centers and that your hospital should be an acute stroke center. And if it's not an acute stroke center, you need to, the EMS needs to bypass your hospital and go to other places. So what's the basis for making that claim? Well, they point out that there are a lot of studies, and you have a bunch of them here in the chapter. 2 through 12 are all studies about stroke outcomes in stroke centers compared to in regular old hospitals. And what do they find? They find, although none of these are randomized, they find that the people in the stroke centers do better. And they find it consistently, and the magnitude of benefit is pretty strong. They've actually done things like comparing a stroke team versus a non-stroke team, regular medical care. Big differences. A stroke center, a stroke ward versus a non-stroke ward. Big differences. But interestingly enough, there's one of those studies, I don't remember which one, but you can look it up, it's easy to find, where they compared a stroke team in a stroke ward versus a stroke team on a general hospital ward. And what did they find? The stroke ward did much better. So it wasn't the experts on the team, it was something about the stroke ward. What was it about the stroke ward, you think?
Time frame of study?
Time frame of?
Physical therapy.
What?
Physical therapy.
Physical therapy. They turned them, they clapped them on the back. They prevented aspiration. They gave them Tylenol if they had a fever. Fever causes increased metabolic demands to the brain. They started rehab early. They did all nursing things. It's fascinating. It had nothing to do with medical expertise. What's the point of that? The point is we could all do it, but we don't. We could all do it. It doesn't take expertise. This is not about you're a super neurologist who's interested in stroke. It's a matter of good nursing care. So on the one hand, we could say, well, we could all do it. On the other hand, unless we do, we have to admit that it's better if they do it. Okay? That's true. Now, this has also been shown for congestive heart failure wards, diabetes wards, COPD wards, and probably a few others that I don't know about or that I can't remember. And it's all about paying more attention to the patient. We should all know this. Doing sort of basic care matters. And when you're interested, when this is your job, we take care of strokes, you do those things. You have protocols for them, the nurses do them, everything gets done better. So it makes a lot of sense. I could see an argument for a stroke center. On the other hand, why would you need to bypass your hospital? Why would the paramedics want to bypass your hospital? What is emergent about giving Tylenol or clapping them on the back? Well, obviously, there's nothing. It's interesting, if you read this abstract number 1, if you read the article, they compare it to trauma centers. They say, just like trauma centers, stroke centers. But it has nothing to do with trauma centers. The reason a trauma center works is because you've got to make rapid decisions and decide who goes to the OR. What matters in a trauma center is people who know how to take care of trauma. What matters in a stroke center is good, basic, standard nursing care. So there's nothing emergent about a stroke center. And again, we could fix the problem by incorporating the things that stroke centers do in any community hospital. Or we might say, well, after we've got them all tucked away and everything's stabilized, and we've done all that we need to do, we can transfer them to a stroke center, to a special unit where they'll take good care. But there's nothing whatsoever emergent about any of this. There's no hint of it being emergent. Well, what is the only thing that's emergent in stroke? Giving them TPA. So a lot of community hospitals say, we don't give TPA because we've never done it, and we don't have an ICU, and we're uncomfortable, and we don't have neurosurgical backup, and whatever the reason is, a lot of places are reluctant to give it. So that would solve this problem. You have to give it if you want to be a stroke center. If you want to be able to advertise you're a stroke center, if you don't want to lose all the stroke patients, most stroke patients never qualify for TPA, but if you don't want to lose them, you have to be able to give TPA because that's one of the criteria. And if you don't want to qualify, that's fine. We'll just bypass you and we'll take all the stroke centers to somewhere where they're going to give TPA. And what's the rationale for that? Well, we're not giving enough TPA. So really this all comes down to, is TPA any good? I've been saying for a long time, since the mid-90s when they first started writing about this, that I don't know if TPA is any good. I do know that it harms some people. I do know, or at least I suspect, that it helps some people. I'm pretty sure it helps some people. What I don't know is, does it harm more people than it helps, or the other way around? That's the thing we don't know. Now, there is some data about this. How do you know such things? Well, you do a randomized trial, right? So the NINDS trial, as many of you know, is the trial which all the supporters of TPA for stroke use to claim that it's good stuff. And how well did it work in NINDS? Do you remember? This is the big study. Everybody got to know about it. It's in there. It's number 13 or 14. I just put it in just so you'll have it as a reference. They did this in a grand total of 624 patients. And in those 624 patients, there was a 30% improvement in the group that got TPA compared to the group that got placebo. 30 out of 100 did better. Is that true? No. 30% is a relative number. It's not an absolute number. So it was 12 out of 100 who did better. There was no difference in mortality, no statistical difference. But there was a 12 more patients out of every 100, or a 30% relative difference in the number who were able to go home by 90 days and live independently, using a particular type of score for the outcomes. So 12 out of 100 is still not chopped liver. It didn't save lives, but it was better. What's the problem with that? There are three problems. One is, it's not the only randomized trial. When it was published, there were 5 randomized trials. Now there are 8. How many of the 8 showed benefit? 1. It's the only one. Now, if you had only one study, 1 out of 1 which showed benefit, and it was a 10,000 person study, you'd probably be, well, it'd probably be a good idea to check it again. But if you have one study and it's 600 patients, 300 patients who got treated, then you really ought to check it again. And then if you have one study out of 8 that's positive and 7 that are negative, well, it's sort of hard for me to imagine why you would say, let's believe that one and not the others. Well, there is the old coin trick. This study had slightly different parameters than the other studies. It may even have had critically important differences, because that's the only study that used it under 3 hours. Some of the other studies did 4 hours, some did 6 hours. But all the others are negative. So again, it might be that the 1942 penny is the good heads penny. It might be. But it might be you just do 8 studies. And in fact, if you look at the results of these 8 randomized trials, in the worst ones, it's terrible. Doubles the mortality. In most of them, it's moderately bad. And in this, a couple of them, it's sort of neutral. And in this one, it's minimally beneficial. That's what you would expect to see if you did 8 studies of the exact same coin. Some would get 7 heads, some would get 3 heads. That's what it looks like. But maybe this really is the good heads coin. We only have one of it. We've never repeated it. They always say it's unethical to repeat it. We already know it works. So how could we repeat it and give placebo? But they've been repeating all the negative studies. In fact, there's one ongoing trial right now, the International Stroke Trial 3, which is repeating a 6-hour study, even though 7 out of 7 that went beyond 3 hours showed harm. What's the ethics in that? So anyway, so that's sort of as a little bit of a backup. There's a second thing that's potentially wrong with NINDS, and that is maybe there are some problems with the study itself. What kind of problems? So there were 624 patients in NINDS. Half of them got treated between 0 minutes and 90 minutes. And half of them got treated between 91 minutes and 180 minutes. Now, how do you get treated in less than 90 minutes? How long does it take you if somebody gets into your emergency department to diagnose the stroke, send them to the scanner, get informed consent, get the drug, and give it to them? Well, at Houston, which is the most missionary place in the universe about this, it takes them on average about 70 minutes, 67 minutes. So you basically, in Houston, you have to have your stroke in the CT scanner if you want to get treated. Most places, it's got to take at least 90. How did they get people in the first 90 minutes? How'd that happen? And half the patients in NINS were in the first 90 minutes. Well, it didn't happen by chance. It happened by the rules of the study. When you were a center and you put somebody in over 90 minutes, you could not put another person in until you had one less than 90 minutes. So it took them a really long time to do the study because there are no people who you can treat in under 90 minutes. It was exceedingly rare. So does that matter? Well, imagine if you were treating blood pressure, for example, and you wanted to know whether a blood pressure of 40 and a blood pressure of 80 had the same outcome. And you were trying to test your drug, and you stacked it with people with blood pressures of 40. Well, that wouldn't be fair. If you wanted to know the average result, if most people have blood pressures of 90, you can't sort of average it. These guys themselves published a paper, it's also in there, by Marler, where they said the early group actually did much better. Now, if the early group did much better and the average effect was 12 out of 100, you got to assume that the later group, it wasn't as good as 12 out of 100. Was it 6 out of 100, 3 out of 100, 0 out of 100? Well, it wasn't 12 out of 100, that's for sure. And in real life, there is nobody in the early group. It's almost exceedingly rare. So the average result would be more like the 90 to 180 minute group, but we don't know exactly what that result is. But they have published saying it's much less good in the 90 to 180 minute group. In addition, it just so happens, just by strange coincidence, that in the 90 to 180 minute group, the only group we should be looking at, just by chance, the patients who got TPA had much less severe strokes than the patients who didn't get TPA, the ones who got placebo. So for example, 4% of the TPA group was in the worst type of stroke, and 18% of the placebo group was in the worst type of stroke. 18% of the TPA placebo group had the least bad stroke, 28% of the other one did. That is to say, before they ever got treated, the differences were greater than the differences that are reported afterwards, which is pretty amazing. That's just by chance. By the way, the single best predictor of outcome is how bad is your stroke? So a lot of us said, wait a second, we shouldn't even look at the 0 to 90 minute group. And in the 91 to 180 minute group, it looks like the entire difference is because they were less sick. Subsequently, in responding to that concern, they have reanalyzed the NINDS paper. And recently, the Heart Association and other advocates of this drug have said we do have new evidence. We now have new evidence. We have two types of new evidence. One is we reanalyzed NINS, and the other is we did a meta-analysis of other studies. None of that's new evidence, of course. It's not new evidence, just looking back at the old evidence. In the reanalysis of NINS, which you have in there, it's by Ingalls and Company, in that reanalysis, they concluded that they were unable to show, and this is by independent statisticians, unable to show that the imbalance that I just told you about is the reason that TPA came out better. Now, when I've talked to them, they've acknowledged that they didn't say they've shown it wasn't the reason. They just say they're unable to show that it was the reason. There's a big difference. Just because I can't prove that it was bias is the reason that you had these outcomes doesn't mean it wasn't. And in fact, it's almost impossible to show it because if you think about it, there's only 300 patients got treated. And if you're looking at subgroups, there's no power to show the difference. So it looks like they started out with really bad strokes in the placebo group, milder strokes in the TPA group. They ended up with slightly worse outcomes in the placebo group. It looks like that might well be the reason. But I can't tell you for sure, just like they can't tell you for sure the opposite. But it sure looks that way. Now, so let's go back again. So one is it might be by chance. It looks to me like it is by chance. They just were less sick patients. But even if it isn't, it's only one study. And by the way, when they did their statistical reanalysis, I forgot to tell you, they didn't look at the 90 to 180 minute group. They looked at the whole group. What I really want to know is what was the difference in the 91 to 180 minute group? That's the only people I care about. But in any case, and even if it was, even if NINDS is right, it's 1 out of 8 studies. And it's a small difference. And in the 90 to 180 minute group, it's an even smaller difference. Now, there's a third thing. And the third thing is, even if they could do it, even if in expert hands, in randomized trials, it is better, that doesn't mean it's better if we do it in the community. I don't think they've shown it's better, but even if they did, it doesn't mean we can do it. So let's look at what the community is about. And the community, there's a few articles that I pointed out for you. So I'm just going to go back over some of this. Not all of it's new, but I'm going to go back over it some of you. There's a few studies where people say, we used it in our hospital and it was really great. Those are sort of silly, right? Because they're usually, we used it in 15 patients, and who's going to publish their 15 patients? The ones who had good results or the ones who had bad results? So it's hard to know much from that. There is only one large study which said we used it and it was really good, a community study. I put it in there. It's called the STAR study. The STAR study is the report of the use in a large number, 600-some patients, from 58 out of the 83 centers that participated in the Genentech-sponsored Atlantis double-blind trial. The Atlantis trial came out negative. 58 of the centers then continued to use it and published their results, and they said, you know, it came out really good. What's wrong with that? What happened to the other 25 centers? Why are we only hearing about the 58? Why not all 83? Well, I've asked them this. They've never told me. I'm just going to take a wild guess that those other 25 may not have had as good results as the 58. What about where there isn't publication bias? Where we know how it actually came out in an entire community. There are only 2 such things in the United States. There are now 4. The 2 in the United States are in there. One is by Katzen from Cleveland Clinic in Ohio. That's in there. You can look at it. They looked at every hospital in Cleveland that gave this drug. Every hospital, period. And they looked at their outcomes. And guess what their outcomes were? Terrible. Much higher death rate, much higher bleed rate, much higher everything bad than in the NINDS study. By the way, 50% of the patients had a protocol violation. They got it when they shouldn't have gotten it. So defenders of TPA say that's not fair. You gave it to the wrong patients. I'll only point out 2 things. One is even the patients who were in a protocol violation had terrible results. And second is the reason we want to know how it happens in the community is because some things happen like protocol violations. So if we want to know how it works in the community, we can't say, well, it's not fair because it was in the community. The results were terrible. Well, Dr. Katzen, who's a neurologist, got a lot of criticism from her colleagues. And they said, you've really screwed this whole thing up. And so they had a big QI process at the Cleveland Clinic. And for several years afterwards, I heard from the neurologists, every time I argued with them, from the advocates of this, they've fixed it at the Cleveland Clinic. It's better now. That doesn't count anymore. And I waited and waited and waited to see how they fixed it. And they finally published their results. And that's also in there. That's also in the last couple of years. And what did they show? They showed that they were able to diminish protocol violations. Not in all of Cleveland, by the way. This is only the Cleveland Clinic hospitals. Most of the cases were at the University Hospital. And what they showed was that they decreased protocol violations and decreased intracranial bleeds. What's strangely missing from the publication, which showed that they fixed it, is outcomes. There's no outcomes in the publication. They must not have looked. I'm willing to bet a nickel that if they had looked and there were really good outcomes, we would know about it. There's another famous effectiveness, that is what happens in the real world study. It's by Bravata. It's also in there. This is from Yale, and it's everybody in Connecticut who got it. And what did they find? Much worse than the Cleveland Clinic. Terrible outcomes. Now, since then, there have been a few other, everybody got it. And one of them was from Germany, and it's in there. And they looked at the ones who got it and the ones who didn't get it. And the ones who got it, much worse outcomes than the ones who didn't get it. We just did yesterday, or last month, we just reported on the Michigan registry. A lot of people in Michigan very gung-ho about this, University of Michigan. They have a registry where they looked at all the results in Michigan where they gave it. And they found that 13% of stroke patients qualify, but that only 1.7% of stroke patients got it. By the way, that's what you see in all these studies, about somewhere under 2%. If you aggressively try to use it, you get it to maybe just under 2%. So it's not even relevant to most stroke patients. The vast majority don't get it. 13% qualified. What were the results? In the ones who qualified and didn't get it, there was a 4.5% mortality. In the ones who qualified and did get it, there was a 10.5% mortality. In the ones who survived, there were fewer survivors who got TPA. In the ones who survived, over 20% more of them had a bad outcome. They were disabled. Remember, this is supposed to be about, well, it doesn't save lives, but at least it makes for better outcomes. It was much worse. The authors made 2 points. One was the people who didn't get it tended to be less sick. That's why it happened. By the way, the difference in their sickness, they were less sick. The ones who didn't get it were less sick. The difference was 4 points on the NINDS stroke scale, which is less than the difference between TPA and placebo in the NINDS trial. So if that really explains this massively bad results, then it certainly explains the minor good results in NINDS. The conclusion of the authors, 13% qualified, only 1.7% got it. They did terribly. What's the conclusion of the authors? We are doing terribly. We only gave it to 1.7%. We should have given it to all 13% and killed many more. That's really the conclusion in the journal Stroke. We are really doing poorly. We're not giving it to enough people. Okay, where does that all lead us? I've got one other little thing to go, and then I'll summarize. So then at the end, all of this is in here. Almost all of it is in here. There's also a really fabulous perversion of data, number 25, which is another thing. It's a registry run by the manufacturer from Canada, which is an extraordinary story of lying, of presenting facts but pretending to present different facts. I don't have time to go over it, but it's really amazing. And there's something in the chapter you can read a little bit about it, but it's astonishing. They claim to have measured one thing, they report the results, but it's actually not the results of the thing they said they were measuring. And they don't tell you. You have to sort of figure it out. But in any case, I'm just going to go to the end. To skip to the end, there is an article which was published in the Medical Journal of Australia by Donnan, which is number 28, which looks at strategies to improve stroke outcomes. And this article was published in Medical Journal of Australia a couple of years ago, and in it, Dr. Donnan was singing the praises of stroke units. And he pointed out that stroke units really save a lot of lives. They save more lives than anything. Well, I was asked to write the editorial to this, and I pointed out that he had shown that a single aspirin must save more lives than TPA. Not just lives, better outcomes in every way than TPA for stroke. How could that be? Well, because even if you believe NINDS, you don't believe any of the negative studies, and you don't believe that we do worse in the community than they do in the studies, even so, you only give it to a small percentage of patients. You can give a single aspirin to everybody. And there's huge data, not 600 patients, but 30,000 patients consistently showing that you save one life out of every 100 patients you treat with aspirin. So if you work out the math, you have to have at least 10 times more effect of a single 1 penny aspirin than TPA. Without any controversy, without any intracranial bleeds, it has to be more effective. That was the editorial I wrote. I said, no matter what assumptions you make, the best possible assumptions you can make for TPA, it still has to be not as nearly as good as a single aspirin. Well, that didn't sit well with Dr. Donnan, because they had just published this data which proved it. And they didn't like that. So what did they do? They recently wrote, my favorite paper, one of my favorite papers in this whole chapter, which is number 31, I think it is. Oh, no, sorry, 29. 29, it's by Gilligan, but Donnan is the senior author. They then go on, they republish their data, and they said, you know what? Stroke units are the best, but TPA saves more lives than aspirin. Now, I just said it doesn't matter what assumptions you make, it cannot save more lives than aspirin. It cannot save nearly as well as aspirin. And they said it does. So it just proved me wrong. It proved wrong that no matter what assumptions, there was an assumption they made that I couldn't think of. How did they figure out that aspirin wasn't as good as TPA? The way they figured it out was, first of all, TPA could be given to 19% of stroke patients. We've just been talking about it. You give it to 2. It could be given to 19%. It's pretty cockamamie reasoning that they got there. But I'm not even worried about that. The assumption that they made that was wonderful, that proved that aspirin wasn't so good, was you could only give aspirin to 28% of stroke patients. How is that possible? You can only give aspirin to 28% of stroke patients? You know how they made that assumption? All the others are already on aspirin, and therefore they can't benefit. Stupid me. I realized that insulin is useless in DKA. In fact, I don't even use it anymore since I read this article because they're already on it, so obviously they can't benefit. Beta aerosols, throw them out. They're useless in acute asthma.
Are they saying they've broken through the aspirin and still have the disease?
No, they're not saying anything like that. They're just saying, no, because a lot of patients in the studies were on aspirin. They just said, you can't benefit because they already got the benefit, so there's no extra benefit to giving it to them. I love it because it just points out the lengths to which people will go to say these. So let me just sort of summarize this. I've given you this whole thing again. Let me tell you what my position is. It's the same position it's always been. It would be nice to know. People say, isn't it a tragedy to not give TPA to somebody you could save? And I say, yes. But it's also a tragedy to kill somebody who would have otherwise done well. I say all these lawsuits, by the way, it isn't just the Heart Association that's pushing us to use this, trying to increase use. It's also the legal profession. There's all these lawsuits about you didn't give TPA. And it's the government. There's all these JCH regulations. And there's laws, state laws and federal laws about stroke centers and giving TPA. They're trying to solve this, what I think is a scientific controversy, by forcing us to do it, which is really the reason I'm in this, why I'm interested. I don't think it really matters. My best guess is that TPA probably hurts a few more people than it helps. And that if we give it in the community, it hurts more than that. But that overall, it's pretty close to neutral, and very few people get it. So it's really not worth spending a lot of time on, except that this is the type of thing that I think we should all feel bad about. That we're being forced to do this, and that it's money and politics and legal profession are making us do something rather than trying to solve a scientific argument. So I don't believe that we know for sure how it will work out. I think there's pretty good evidence that it's at best pretty close to neutral and maybe a little harmful, and that if we give it widely in the community, it will actually cause harm, more than a little harm. But I don't know that for sure. There just isn't enough information. I just don't think we should let them do this to us. Tell us that we must use a drug, force us to use it with regulations and legals and all that other stuff, when there's a lot of controversy about it based on all of this craziness. So that's why I've been involved in this so much, even though in the big picture of public health, it's only a minor thing.
Three questions. Does our American College have a policy statement?
There are 4 policies of the 4 emergency medicine organizations in North America. Not one of them says it's the standard of care. It's one of the best things I have to defend doctors. They range from, we don't know, to don't use it. But not one of them says it's the standard of care.
The second part is going to be, for physicians who use it, how do they present informed consent on this issue?
So there's also this whole issue of informed consent, and it's a great question. I don't have time to really go into it, but you can imagine that this is sort of the crux of it, and patients often come in, or their family comes in knowing about this life-saving clot-buster drug. CBS News had a thing that says saves lives. It has never, ever, ever, in a single study, ever been shown to save a life. It's never been a scientific claim of it, but that's what patients believe. So what you say to them, when I give informed consent to the patients about this, and I always do, I don't just refuse to give it, I give them informed consent. Surprisingly, a lot of them don't want to take it.
You say there's as much risk of you bleeding versus benefit, or how do you say it?
I tell them that there's a controversy here and that there is the potential. Some people think it works. There's most of the studies don't show, there is increased. Go ahead.
Interventional neurologic radiologist in the localized.
Nowadays, at places like UCLA and other places, they're doing other things. They're talking about arterial. They're talking about little coils that you go and get out the clot. Maybe, but there's no data. There's essentially no data. And at UCLA, where they're selling their own catheter, and they actually published this in the Annals of Emergency Medicine with a picture with the name on it of their particular catheter, which I think is sort of unethical. Talk about the concept. Don't show your catheter. They did that. I've been asking them for a long time. They're always talking about how great it is. I say, what are your results? How have you done? I don't know. Again, I'm just going to guess. If they were great, I think we'd probably know. There's no other place where we know that you can save neurons once they're dead.
Have any of those lawsuits been resolved one or the other?
I've now had to do at least 15, 20, 25 lawsuits. Some of them are terrible care, where somebody figured out, oh, help us, it wouldn't have mattered anyway. And those usually get settled because, it doesn't really matter whether or not it meets the formal definition of causation. If the care is really bad, the jury is going to vote for the victim. So there have been a couple where they've made settlements. In the ones where it's not, where it really is, they range from the care was okay, good, terrific, and there was an informed decision not to make it. Most of them have not yet been settled, but have not yet reached a decision. But I can tell you that not one of them has paid any money yet. And at least 3 or 4, maybe more, have been thrown out. And the 2 that have gone to a jury have both won for the doctor. Last one.
Isn't it true that the risk of TPA goes up with age and smaller body size?
The risk of TPA goes up with age and smaller body size. I know about age. I'm not sure about body size, but yes, it does. But that doesn't mean you shouldn't give it, because in cardiac, for example, the risk goes up with older age, but the baseline risk is so much higher that even though you don't get as much relative bang for your buck, overall you get more benefit because more people are going to have a bad outcome. Personally, I think whatever you think about this, for me, giving it to somebody who has a minimal stroke or a minor stroke, that's really terrible. Last one.
Is the issue of litigation not offering it to the patient and explaining, or is it?
Mostly it's not offering it. Sometimes it's not offering it. Sometimes they offered it, but the patient didn't want it. Sometimes it took an hour to get the CT scan. And how come you took 2 hours to offer this and now they're out of the window? There's all sorts of different things. I have defended one doctor who said, I didn't offer it because I don't offer things that I don't think work, that I think are harmful to patients. I didn't offer it. I made that decision. And although I don't take that stand personally, I think it's a little foolhardy, I did defend him because it is true. You don't have to offer everything. But I think it's a little foolhardy in a world where they know about it and they're going to hear about it and there's a bad outcome.